the advice would be, look at innovation not just about technology. Look at, firstly, what problem are you trying to solve? And what is the human impact, positive human impact that can be solved from that problem? And then what is the innovation, whether that's a change in a policy procedure, care model, or technology?
Welcome back to our podcast, Talking Aged Care, where we're joined by Amanda Archer from Warrigal. Amanda, you are the Chief Design and Growth Officer at Warrigal. If you could please go through your background and explain your experience in the sector to date.
Yeah, no worries. So as you said, I'm the Chief Design and Growth Officer here at Warrigal, and I've been here probably just under 3 years now. I don't come from aged care, been in the sector for the same amount of time. I am early childhood based, so I've come out of education and early childhood and moved over to this sector. Chief Design and Growth Officer, a number of things sit in my portfolio, and I think the most important one that we're talking about today is the innovation sits within my portfolio.
Yeah, fantastic. There's a lot of we talk about childcare, vulnerable groups, a lot of cross similarities between both groups. Did that assist you in your role when you stepped into your role at Warrigal?
Yeah, it absolutely did. And I think I say to people at times, I feel like I can just white out the age groups, particularly in the regulatory space. Both are known to be highly regulated, and justifiably so, with the vulnerable cohorts that do enter both systems. But there is some differences as well. Some similarities are things like in early childhood, in the first years of our life, we get things done to us or for us or on behalf of us. And then as we age, and particularly in that middle age space, we can kind of engage in whatever we want to engage in and, have that free will and autonomy, go bungee jump or do anything like that. And then as we age and move into the aged care space, and whether it's informal aged care or not, you kind of enter back into that otherness, and you have people do things for or on behalf or make judgments about what you can and can't do. So I think that's very similar. I think some differences are the investment and innovation and things that happen in the early childhood space that you don't see as much in the aged care space as well. So that's probably a key difference.
Yeah, I agree. There's a lot of similarities, and I think within your role, especially with designing growth, that's a really interesting role, but it sort of talks a lot about the organization in terms of strategic planning and what you want to do. You don't want to sort of be cut by the same cloth and go off the beaten track. You want to do things differently, and hey, will you potentially fail? Yeah, you will, but it just means that you're striving for greatness. You're striving to improve older people's lives. And I believe if we constantly do the same thing, we are going to get the same results. So I think it's definitely needed. But yeah, excited to hear more about what's on in the pipeline the next 12 to 18 months within your role. I wanted to talk to you. So the word innovation, it's I believe, overly used. And when it's used in the right way, people do stop, pause and say, that's really interesting. Now, it's sort of the question which is asked a lot. Why does innovation in aged care often move slower than expected?
Yeah, I think people reach for easy answers, and you hear it all the time when you start talking about this, about risk aversion, maybe leadership, like long leadership, old leadership, or conservative cultures. But I think what is missed there is a structural reality that faces aged care. We're running 24-hour a day, 365 days a year, essential service for some of the most vulnerable people within our community. And most importantly, we're generally running on margins that don't exist. You just have to look at the Stewart Brown data to show that majority of providers are running at a loss. And when you're running in a deficit, you don't have the capacity. You're thinking about the next month. What does that look like? How do we get to the next stage gate? Not necessarily what do we do in the medium and long term. And innovation, it requires slack, and it requires the financial and psychological headroom, particularly to ask, what if this doesn't work and what if it fails? And when you don't have that capacity and that space to ask those questions or to take on those risks, you kind of get stuck in being able to even implement things. I think there's two key things that people underestimate for us for innovation in aged care. And number one is the stakes. A failed pilot in aged care or in human services can actually have significant impact, and people can end up harmed if an innovation doesn't succeed. But outside of these sectors, and a failed innovation could just be, a blip on the bottom line, a blip in the budget, and those kind of things. So there is a different risk profile. And secondary is the regulatory load. I did think that early childhood was overregulated, highly regulated, and then I came to aged care and I saw not just the level of regulation, but the sustained change in regulation that's happened for nearly a decade now. Each is legitimate reform, each is working to, make people safe, but the change and the scope and length of change just takes up all the organisational bandwidth. So it's not that providers are sitting still and being slow in innovation. They've been running really fast to try and just do the reform and do BAU and ensure that their organisation is meeting the next level of requirements, let alone thinking what's beyond there. And I think, people say it moves slowly. It affects care, safety, and people's homes, people's lives. Regulation, privacy, clinical risk, and impact matters. And so innovation does need to be careful, useful, and sustainable in our sector.
I agree, and you just mentioned it there. I feel like providers are constantly running where therefore they can't catch up, and there's been instances, and I've had quite a few roles in aged care, from facility manager to quality and compliance, looking after sort of 8 homes in a portfolio. But the frequent sort of theme is that, look, let's say we were to find something that's non-compliant and pass it on to the facility manager. Yes, they would address the most serious things. But the other thing's just, it's a piece of paper on their desk. It's just business as usual. It's so rapidly evolving, the landscape and the issues and the reporting requirements. So I believe whilst the reforms have at times helped, there needs to be some common sense from the department and the commission to say, look, we want to incentivize providers. We need more beds. How can we do that? Let's look, communities are definitely not trying to create unsafe environments. We're all humans. If a mistake is made, let's not throw someone under the bus, but let's see, how we can learn from it, support, and provide the best environments for our, aging population. And I think the issue is, one of the issues is that in the media, there can be a lot of disinformation, and you saw the Four Corners and different episodes in aged care. It didn't really paint any good light. There wasn't really anything good that was said. So there's sort of perception that, aged care and providers are trying to make a lot of money, and now with the RAD retentions, trying to explain to families that's good. They can reinvest in the buildings so that the building is still nice in 5 years' time. But what do you think people outside of our sector fundamentally, misunderstand about operational realities in aged care?
I think the biggest one is the regulatory requirements, and I think this is within any human services sector as well. When you are looking after people, when you are caring for people, when you're partnering in people's lives, because that's what it is. We partner with residents and we partner with families. It does generally come with it's not that hard. I look after people at home all the time. Just look after them like I would at home. And it's that misunderstanding of all of the requirements that sit behind it. And please, this is easy to misread. I'm not saying that regulation is important. It's critically important. The sector needs accountability. It needs quality. There's regulation that's proactive. It safeguards residents. It creates accountability. It builds that public trust. And I think anybody in this sector will defend it. But there is a category of burden that, you need to think about. Is this about the system's need for documentation and proof that something happened, rather than whether things are happening well? So when we have a care worker or an RN spending more time documenting an interaction than what they had actually spent doing that interaction, that's not serving a resident, it's serving an audit trail. And that's not a villain story about red tape, but it's that real tension between accountability and presence. And that's misunderstood out in the world. Unless you decide to pick up the Aged Care Act and the rules as somebody out in the public, you have no idea what the requirements are. All they want is for their loved one to be safe, fed, happy, listened to. They don't understand that that comes with thousands of pages of documents that go with it, and care minutes and funding requirements, and they don't understand what are we actually funded for, which is becoming more and more critical as more and more people age. And the system cannot fund aged care the way that it's going. Operators can't work within the funding that's available now, let alone when it starts to stretch more and more and more. So I think that's the biggest misunderstanding is the actual requirements that are happening behind the scenes that do have an impact on that one-to-one relationship that we can have with residents.
Yeah, I agree. Well said. I believe, there's a lot of, and we've done it before, I've worked with providers where, honestly speaking, you're doing something to tick a box. Like the impact or the outcome, it's not really important. It's about ticking a box and making sure that you're covering yourself, or even as part of sort of baseline governance, sending an email to a certain person. So there's an audit trail that you've actually informed them and told them to do something. Therefore, they haven't, it's not you. It's sort of not, that they haven't done it sort of thing, but as a manager, you can't do everything and you have to delegate effectively. But I believe you're right. There needs to be that balance of creating public trust, but also you need to spend more time and get back to, nursing of old where, Florence Nightingale, that bedside nursing matter, spending time with someone, talking to them, understanding and providing empathy as opposed to just really transactional, quick, and let's get this notes done and make sure that we're, from a risk perspective, sort of secure. A lot of the previous episodes and guests, we spoke about the middle layer, so management on the front line and the sort of the feeling of exhaustion that they felt. Do you believe providers can genuinely innovate when teams are already, emotionally and operationally exhausted?
It's a great question, because it's very easy when we work in a work in head office to make a decision.
Yes.
To put something new in when the teams are exhausted, and then wonder why things don't work. And we all know about the impacts. We've seen survey after survey that show high levels of burnout, anxiety that's happening across our homes. People are coming in, residents are coming in, more and more complex needs. That has emotional load as well on our staff. And I think a simple answer is no, you can't. No, you can't innovate and implement when people are at the exhaustion and breaking point, because it doesn't just slow it, it changes what's even possible. If you are working with teams that are at that exhaustion phase, what they want to see is an innovation that immediately shows an impact. That's what they're craving. Put something in that immediately will make my life easier. And we all know that innovation, and particularly true innovation, it doesn't work like that. If you have something that's really innovative and it goes in and there's no friction or change or anything needed, I question, are you actually making a change then? Because any change, whether positive, negative, or in between, instantly causes friction, it causes conversations, it causes people to go through their own grief cycle on change, and it also generally heightens workload before it lessens workload. Even if that's only for a short period of time. So when you are even a brilliant idea, if you're implementing it in an exhausted workforce without that support and knowledge around it, it will fail. People are skeptical, particularly when they're at breaking point, and that skepticism it's scar tissue of how many times we've tried to say, just do this and it'll make this better, but then does it actually work out that way? So yeah, I think that you need to be conscious of it, and you need to plan around how do you show small, quick wins that will then allow the bigger wins to come later. Like, your innovation should reduce pressure and support staff and make care easier or safer, but how do you actually put that in place and get people on the bus when they are exhausted is the biggest question.
It's always hard, like balancing, and I know that, for example, employment surveys and satisfaction surveys that are distributed yearly are important, but I think more important is what you do with that data, right? Like what you actually, use it and how you implement it. So if you do implement changes, but you're right, in order to make a change, there needs to be a conversation, whether it's unfortunately confrontation, you've upset people, there needs to be definitely starting, conversation starters. Otherwise, you haven't really done much. You've just molded to the same system. In terms of, we always look at, different models of care and what people are doing. And we always use the words in aged care of best practice, especially from a clinical perspective. And there's some fantastic sort of, models of care and household models and different approaches, which everyone watches closely and sort of sees what they can do with their own organization. What do you believe separates organizations that evolve well from those that remain stuck in a kind of survival mode?
Yeah, so I'm going to come back to the structure again, which I know I said in the first question, but I think it's a critical element. And I think if you look at organisations that are evolving from it and moving out of that survival, it's having the dedicated resources within the organisation that are responsible for looking at the medium to long term. So you need somebody that's not in the operational day to day and that's thinking about those next time frames. And having boards that are comfortable, I'll now say, with productive discomfort. So not recklessness at all, but the ability to hold a question that doesn't yet have an answer. So you do need a board that's willing to sit in that ambiguity if you're trying something really, really changing. Like we have an Australian First trial that we're doing here. We didn't know what the answers would be. It's never been trialled in an aged care home. So what would it look like? We couldn't give those answers. So having boards that can sit in that productive discomfort, still ask the questions, still have the governance and the scrutiny, but can sit in that kind of grey area. And I think you need a culture where it's safe to say, this didn't work. Fail fast and fail often is definitely one that I think you will see that in organisations, the permission to fail and the permission to be able to do that. The other thing that I'll talk about is what I call cultural antibodies, right? So every organisation has this. So it's like the organisational immune system. They're the deeply embedded practices, they're the risk cultures, they're the hierarchy that you might have, and particularly they're the unwritten policies and procedures. Every organisation has them, no matter what. And what those things are really good at are detecting anything new and treating it as a threat. So a new idea, particularly one that changes how things get done, who decides what gets done, anything that changes that equilibrium doesn't often get rejected by open opposition, right? It's neutralized by those little resistances that go through. The same way a body attacks something that decides it doesn't belong. So it's like death by 1,000 cuts rather than the big opposition. So that's and again, I'll go back to my previous. When you start to see that friction, that's when you know, though, that you've got a big change. Whether it's positive or negative, you'll find out later. But the solution isn't to fight the immune system harder, but enforce it through. It's stopping and thinking about how are you introducing it? Are you introducing it at a home level? Are you building it with people with them, not for them, so that it arrives, people use that adage of plant the seed. So work with them. And then you make the small changes. So I'll use radar tech that we're doing in our Goulburn site as an example. That technology has the ability to do so many things. And what we decided to do is we'd start with one component. So we'd start with that and we'd see what that looked like. And then we add on as we go. So we start with the smaller things, the easier things that we can do, the things that make a shift easier or make an insight into a resident easier or bring a benefit straight away. And the third is to give air cover and time, right? So allow those small changes and allow it. And the last thing I'll talk about, and I know this is a word used all the time, but it's champions. You can't make your way alone past those little things, particularly if you're in the head office making a decision that's for on the floor. You need to have the people that you can find that will trust, and you back them and they back you. So it's someone who can stand up in the tea room and go, yeah, I was skeptical about this too, and I didn't think it would work either, but you know what? Here's what changed my mind. And that carries more directive than anything from head office, from a CEO down can do. And I'll continue to talk about Goulburn because this is the clearest example that we have. Our radar trial, like we're only a few months in, so hesitant to call it a success, but early indicators are very positive. But the success isn't about the technology. The success is our general manager, Kat, 100%. She turned what could have just been a decision made by people sitting here to go, this sounds cool and I think it will have a good impact. But she made into it something that that home genuinely owns. And whenever someone asks me what made Radar Tech successful, it's not the technology. The radar is a tool, but Kat is what made it successful. So she's what makes it work, and that's what you need to do. And that's the difference with organisations. And it is from the board down. The board having it's being able to sit in that ambiguity, the senior leaders team being able to select and identify what to do, through to the people that are actually doing it, and making sure that the same message and the ability to raise issues, like when you're implementing something new, you need to have your eyes and ears open for the fact it can be a failure from day one. So the ability for people to open a new door and go, I actually don't like the way it's doing A, B, or Z, rather than them just seeing it out, but the ability to talk through those really tough conversations about how what you thought was going to happen never happens in real life. And the project doesn't belong to one person. It belongs to everybody. Like everybody has a subject matter expert. Like I'll sit in meetings and somebody will say something and I'll go, I never even thought about that. So allowing everybody into your space, I think, is another thing. And that organisational permission to have so many people involved in something so that you come at it from all aspects. It's not one person and it's not one idea. It changes. It's a snowball effect.
It's good to hear. It talks a lot about culture. When you mentioned Kat and her management style and how she's utilised a tool there, but I really believe about it's about capability and how can we get the best capabilities out of our people. So the best managers that I've worked with, regional managers or execs or CEOs that I've worked with, they do what I call the shield and support. So they won't allow you to feel the pressure they're feeling from the board or the chair of the board or whoever it is, or even at the EGM level, but they'll support you and they'll say, look, let's run with this, let's do this. And yeah, there might be issues or errors or teething problems, but we'll iron them out together and with the aim to improve care. That's the whole point. So, if it's partially successful, then the word successful still features. I would deem that as a success. So we always need to look at things from a granular perspective and look at the compound effect that it can have as well. Your thoughts on this? Do you believe that aged care has become too reactive as a system?
It's so hard to say yes when you have people's lives, right? But I don't think this is just an aged care issue. I don't think aged care has become too reactive by itself. I think the whole health sector and health has become very reactive. And if you look at it, if we just look at aged care, it's a system that is good at responding to deterioration and crisis and not focused as much on preventing it. And I'm not talking about the people in the homes. I'm talking about the system, the policies, procedures, and funding levers. Because I know if you go into any home, you will see people who are working at prevention and who are not just reacting. I'm talking about the systems here. But if we look at funding, funding is weighted towards assessed care needs. The higher the need, the more money you receive. There's no direct financial incentive to keep someone well. And to go back to Goulburn again, but one thing that I missed in the last one, but it's equally important, is the residents and family on the journey of innovation. So we spoke to residents and families about the radar technology and the predictive nature of it and what it could mean. And it could stop hospital transfers and it could identify things earlier. And every single, like we got 95% sign on, every single resident and family member that we spoke to talked about that want of predictability. We had residents talking about, I know that I've got a heart issue and I'm really worried when I sleep, will something happen to me? They want that preventative care, not just the hospital transfer at the end. But the funding doesn't allow, there's not that financial kind of incentive. The system doesn't reward it. So, like if we look at investing in fall prevention, early cognitive support, social connection, all of those are fantastic outcomes for providers. And there are providers across Australia doing wonderful things in those spaces, but it's not explicitly funded. You do that out of your, out of your own pockets. Yes, it does come with less cost later, but if someone deteriorates, you get funding, but that's the reactive nature. And there's also the structural problem that as well, the transition for people between being at home, accessing home care, support at home, coming into residential, going to hospital, coming back. It's like they walk into a brick wall at every single stage of that, and people fall through the gaps. So yes, the system's reactive, but that's because the whole way that health and aging in Australia is reactive. And there's other countries that are doing it where it's proactive and it's a community wide and it's wellness focused, not illness focused. And it's not, this isn't because, again, people don't care. It's about being under pressure for a long time. We need to work towards being proactive, workforce, look at prevention, looking at better care models and looking at the future needs. Because we all know the demographics. We don't have the beds available now. That's only going to get exponentially harder as we move forward. So
Correct.
what do? We need to move to a preventative and an aging strategy and not an illness strategy.
Yeah, interesting. There's a future guest that we have coming on that I was talking about this, and he said to me, "We need to learn," and he's in his 80s. He said, "We need to learn how to age in a healthy way, and we need to describe that sort of last passage as a continuum of life, but we need to start addressing it now." So, and he was quite specific in terms of, he believed certain causes of dementia, whether it's fast food or too much sugar or the things that we shouldn't be having on a Friday afternoon when you need an afternoon pick me up. So there's quite a few sort of take homes there, but I think you're right though. We need to look at, kind of the bigger scale. We are reactive. If we look at aged care, I've always said that you can't look at aged care in isolation. It's part of the wider healthcare ecosystem, and you have to look at it, primary healthcare and bed blocking in hospitals and what aged care does and the purpose it serves. But I believe there needs to be almost, providers are screaming and crying out, "Please give us a break." Commission, please just give us a break. So I think you're right. We are reactive, but there are certain things that we can do to improve that. Aged care often gets a bad rap, and we seem to not address certain things in the room, the elephant in the room, and certain things like that. But what conversations does the sector still avoid having? Honestly,
Oh, that's a hard one. I think if I go back to the silos, so I think if we look at, we are segmented. So we have home services or support at home, CHSP, which we obviously don't also have the capacity to do at the moment. The waitlists are significant. We have independent living, and then we have residential aged care. And the ability for people to move through that system is hard. Beyond many people's capacity at the emotional state that they're in at the time that they're in it. And the sector works in those segments. What we need to do is actually strip it back and go, what if funding followed people? So instead of residential aged care homes should be funded XYZ, and this is the funding that we need. Support at home should be funded this, and this is what it needs. Actually stop and go, what does a person need for that end of life? And how is the best way for them to access that? Everyone talks in the sector about no one wants to live in residential aged care. Everyone says that. Nearly every conference I go to, people systematically say, well, no one wants to live in residential aged care, but what are the options? Support at home, we have 200,000 people waiting. The funding levels are not significant. We don't have the workforce. And beyond
Correct.
that, do we have the society that can, if people are staying at home and the numbers about people dying in their own homes are significant, what does that look like as a society? But they can't access funding because they're not at that level yet, or no one's left the package level that they need. And everyone is fighting for their own buckets. I think if we stepped away as a sector and instead of going, well, I'm a resi provider, or I'm a support at home provider, or I have CHSP, or I'm an independent living and I do this, and we looked at what if we could work with the government to have funding follow people instead of follow sectors, that we could fundamentally change and look at wellness and aging well, rather than people being put into boxes that they might not necessarily fit into. And I think the other question that we need to have comes back to the compliance. And again, I'm not saying, this reforms were undertaken for significant reasons. They were, and needed reasons. But looking back and having a conversation about what regulations are actually benefiting residents and benefiting people, and what regulations aren't. And I think in any human services sector, we have this capacity to kind of do the old school overhead projectors that, that used to go to school, and you have the overhead projector and then you put the paper.
Yeah, that's right.
Yeah?
Yes, that's right.
What human services do is they kind of go, and they put another sheet on top and another sheet on top. So how do you unscramble the egg kind of thing? So what actually benefits and what doesn't? And one thing that really surprises me and interests me is, coming from early childhood, you didn't have much lead time to your demographic that you were going to serve, right? There's birth rates, but you've got the birth to 5. So what does that look like? In aged care, you've got a long lead time. We all know,
that's
and
true.
we've known for years what's coming. And I know I'm not alone in saying this. I'm, not trying to be offensive to the people who've spent their life in aged care, because I've heard them ringing the bell and saying the exact same thing. This isn't new news, but we have known for years what is coming, and we haven't managed to change. So what we are doing and the approach we're taking needs to systematically change to be able to address that. We need workforce, we need space, we need funding changes, we need all of that to be able to meet the needs.
You're right. I think, and you've made a really good point there. It's not just sort of come out of the blue. It's we know that baby boomers are going to get older. We're all going to get older, and we hope that our loved ones or kids are going to be around to tolerate us and look after us. But if that's not the case, and we do need that extra support, what are the options? So, I had a similar conversation with a provider that were looking to do sort of bulk recruitment. And I said, look, we can, even the Department of Health goals, 30,000 nurses in 5 years' time, we can supply, but that's not us trying to beat our chest and say we're great. That shows the problem. We shouldn't look to rob other countries of their resources. We need to think of a way sustainably to source staff from our own shores, but how can we make aged care an attractive place to work? And I believe, there should be embedded into secondary schools, a bit of work experience, because again, yes, whilst we do need registered nurses and care staff in the coalface working, there are so many roles within head office, whether it's procurement or business optimization leads, marketing, PR, there are so many different roles. So you can, like the sector, don't necessarily have to be right there doing the nitty-gritty care aspects, but you can still be making a huge difference. So I think we need to market it well, and really sort of shine the light on, I don't want to sound, like an old sort of American politician here, but we need to sort of, not make aged care great again, but like we need to have that focus on how can we shine the light in it, and how can we, really say we're doing great things here. It's a great place to work. It's not just about the good coffee or, the breath, the breath, so.
It is a great place to work. Like the ability, the lessons that you learn and the stories that you have with people that live with you or open their homes to you or live in your communities. Like it's fantastic. The knowledge and just life experience and humor and just the genuinely great people that you get to work with. Like it is a fantastic space to work. And, people, you hear it, oh, I don't want to do that because of, I don't want to work in a nursing home or I don't want to work here or I don't want to work there. Look beyond, like it's amazing the people that you speak to, the lives that they've lived, the dignity and respect, and being able to share that last part of somebody's life. It's an honor. It's not a burden. And our staff, like obviously I'm in head office, our staff that do that, like you just walk out to any one of our homes and you speak to any of our staff and they are all committed, and the stories they tell you, the emotions they have, like you just need to tap that somehow and get it out into the wider sector, and the relationships that we have with families and the relationships that are formed and the shared role. As I said before, it's a partnership. Yeah, I don't know how you get that essence and get it out, but if I find out, I'll come back to you and let you know.
No, perfect. Thanks, Amanda. No, I agree. It is an amazing place to work. And being from the UK, I remember at a site when I was talking about music that you like, and I've got a very interesting music taste. Everything from A to Z. And I was talking to a resident there that I liked the Beatles, and he said to me that he grew up on Penny Lane, one of the Beatles songs. I thought, wow, how cool! But just the stories that you hear, it's just so interesting. And years ago, he looked after someone, and it's fine, I got permission to say it, but I saw the surname and I said, "Oh, Arnott's, like the biscuit company." And he goes, "Yeah, my grandfather started that company." I was like, "Wow!" So it's just incredible the people that you have the pleasure of looking after. We talk away, and when you really sort of look at people as people, and not as a diagnosis, and you respect and appreciate it, it just changes the narrative altogether. I know that in your role, the word design is there. So this question is very futuristic, but if you had a blank canvas now in front of you and you were able to design the future of residential aged care, how should that actually look like?
Well, I debate like I said before, it's about I want the system to move with the person, not the person through the system. That would be my ideal. So what is really hard is that we have people that have been married and living together for 50, 60, 70 years, and then one of them has a significant health crisis and they need to move into residential aged care and they separate because there's no other choice, right? They have to separate. And what does that look like? And particularly if their loved one that they're leaving can't drive, is far away, the only home that's available is an hour drive. Like, what does that look like? And so we're asking people whose whole world has been with one other person to then move from that other person to come into care. I want to change that. I think that's a system that we could change. And I think I just broke off, but I think I'm back. Yeah, so I would want people to be able to stay where they want to and have the care delivered to them. Now, that might be in a residential aged care home as we know it now. And it might be in a dementia cottage, a small home model, whatever works for them. And I want the system to be able to come around it. And if they want to stay at home with their wife or their husband that they've been with for 60 years, I want the system to be able to adapt to that. That's dreams. If you gave me a blank canvas, that would be my dream space, that we would be able to do that. I think this goes again to the when you become older and you become other. because when you are growing up and when you are living your life, particularly in this day and age, you can declare, you know, I'm socially sensitive, so I don't want to go out with people, or I get overstimulated, so I don't want to do this, and all of those kind of elements. Yet when we reach a certain age, we go, well, we can live with 150 other people and go and have dinner with 90, and what does that look like? That's what I want for whoever you are, whatever your personality is, because that doesn't change, whatever your wants and needs and triggers and sensitivities are, that you can find somewhere when you age to live the end of your life the way that you want to live it. And whether that's, co-funded, government funded, whatever that is, that's what I would like to see.
Yeah, nice. I think it's about really treating people as humans. I spoke to a previous CEO that worked in the sector for a very long time, very well respected, and we were having, I guess you could call it a sort of pub chat, and we were sort of, like what would the future of aged care look like? And he said to me, right now we're in the pub, we weren't having a drink, but we were having a nice meal and a conversation. He said, I'd love there to be, if people did drink, if residents did drink, a pub there or a bar, and on Friday or Saturday not open until late, but they sign dignity of risk and risk assessment forms that if they do have a fall, but they've had a great night or a great time, I thought, yeah, wow. But he goes, because we don't, when we get older, we still have the wants and needs to have fun with our mates and have a laugh and do those sort of things. So it was really interesting. I think we sometimes forget that as we get older, we still want to have those important, meaningful interactions with others. And I feel, it's important. You just mentioned it there, when someone, especially you're married to someone, that's all So when one of them does go into care, the impact it has on that person as well, not just the resident in care. To sort of close and sort of wrap up, in terms of, innovation, we talk about bringing new things in, approaches. How do you believe we can introduce innovation without losing the human side of care?
Yeah, I think that's the most important, is that, we want care that's safe, we want it professional, but we want it human. And I think that's the very big scare that people have as we head down the technological super highway that we are going at the moment. AI is the biggest buzz. AI has been around forever and a day, but, the absolute velocity at which it's moving at the moment, there is a real fear about removing that human element. And I think the biggest question to ask yourself is, if you are looking to innovate, what is the benefit to a carer and or a resident or a human being? What are they getting? Is it more time? Is it predictable? Is it earlier intervention? What is it that is an actual benefit to a human being? Because if it's just an efficiency, that's not innovation, that's cost cutting with a beautiful brochure. So it's about, what is the actual problem that we're trying to solve firstly? What is the human element that we're trying to do with this? And then what is the systems around there that can support that? I think we are in a completely overpopulated market in terms of providers now trying to come out with anything AI. Like, I've been to a few conferences this year. I went to the same conferences last year. There might have been 3 or 4 vendors last year. This year, there's 118, and all with AI
Yeah,
and
correct.
what they can do for you, which is fantastic. But let's strip it back and go, not what can they do for efficiency in head office or cost cutting or things like that, but what do they actually bring for humans? And innovation doesn't have to be technology either. It's easy to get caught up in that cycle and that sweep at the moment because everybody's doing AI and look at what we've gained from it. But it is about that model of care. It is about doing something different. For us, we're in our independent living, we're launching Lake South, which is going to have care within our community village, access there. It could just be about, how do you onboard residents? So we've changed our onboarding to go, how do you make residents then only have to tell one person their story and not multiple different people throughout the system? So I think the advice would be, look at innovation not just about technology. Look at, firstly, what problem are you trying to solve? And what is the human impact positive human impact that can be solved from that problem? And then what is the innovation, whether that's a change in a policy, procedure, care model, or technology?
Yeah, I agree. And it's interesting, that every sort of second or third message I get on LinkedIn is, this AI solution. What can someone sell or do for you? And, and whilst it has been around a long time, but whilst it's good, I think, we need to really understand what's going to be, number one, that will create the best outcomes for our communities and the people we look after, but also, is it relevant? We talk a lot about our workforce, and we're very lucky to have, I guess, sort of migrant, work staff that build up our workforces, but they might not have the best written English. But if they were able to speak in their native tongue and it was translated into English, great! What a great, invention. Add that on to an existing care system. But I believe we also need to make things easier and also be respectful that some of our, a complement of the workforce might not be that tech savvy. So we need to sort of strip it back, and they may not know how to use certain things. So we need to make it easier, and so that the barriers to entry easier. But I think you're right. I think when it comes down to AI, it's not the be all and end all. You've mentioned now, which I really liked, and I revert back to it, and you said it wasn't the tech in Goulburn. Like, whilst that's important, but it was actually the person driving it. So I promise I won't call up Kat and offer her a job, So, but I think, honestly speaking, it does. When we're looking to place, managers, leaders in aged care, it's that wow factor, and it's not like the usual things that you can rehearse for an interview. It's how can you take it, run with it, and actually just make it your own, and be that person. So I think it's important. But Amanda, I really appreciate your time on the episode today, and you've shared some really insightful sort of insights into the sector, into your role. What's next on the radar for the next sort of 6 to 12 months at Warrigal? Any exciting things that you can share?
Well, radar is on the radar.
Yes, nice.
That, and as we look into it, there are some really exciting initial findings that are coming out. So once we get some actual, concrete strength in the data and not just the initial findings, so excited to share that. And the model of care, like we're doing Lake South, we're just looking at what we can do here to really put residents at the centre, not that they ever weren't, but the changing face of residents and the changing face of the demographics. So how do we evolve as an organisation to meet those needs ahead of time, so we know what's coming? So how do we evolve as they come to us? I think,
Yeah, great. Look, really appreciate your time, and thanks for being on.
Thank you.